That's where we're at. I think you guys are on the table over there. No, it's got to be folded up with the highest bill in the other.
We went on ice cream. She wants milk and no, from Renner. A sponge.
Milk. Regular person milk. Nobody should drink milk.
Like almond milk, soy milk,
I think that sure, I'll get there. I'll put my second and then it was not sure. Figure out. Yes. Germany was yes. Recorded right there. It's like Ellie was. Yeah.
Good morning. Thank you for attending this public listening session on shifting drug distribution channels, looking at the issue of white bagging and brown bagging, the purchase distribution of non-self-administered medications. I have to admit that when I was asked to participate, my knowledge of white bagging and brown bagging was limited to lunch and a bottle of wine. So I feel like I have learned quite a lot in the last couple of weeks leading up to this session, and I'm sure we'll learn more today. The purpose of today's session is to obtain stakeholder feedback for legislatively mandated study regarding the practice of shifting drug distribution channels, commonly referred to as white bagging and brown bagging. The HBC was charged with conducting this study through the outside section of last year's state budget. Staff will provide an introductory presentation on the topic to bring us all up to speed and explain that statutory responsibility and introduce some focus questions to guide our public comment section. All in attendance are welcome to offer testimony either in person or through written comments. There's a sign-in sheet for those who wish to testify at the table, I think, when you enter. I would also remind parties that we're going to limit the oral testimony to 5 minutes, but you're more than welcome to provide your written comments, which will be accepted until 5 p.m. on Friday, May 11th. To give us some background on the topic, Sarah.
Great. Good morning, everyone. Well, this is certainly a complicated topic, and that we have been charged with in writing a report and in recommendations, and for that reason, it was critical for us to have an opportunity to hear from stakeholders. So. We have here the background for the legislative mandate for the report. I will talk a little bit about the issue and give some basic definitions, and then we look forward to hearing from you all. So what are we talking about? We're talking about practices that involve specialty drugs. These are high-cost drugs that in most cases are administered by a physician or other provider through injection or infusion. There are specialty drugs in many categories, but we are particularly interested for this topic in, and have heard from stakeholders about the effects of brown and white bagging, particularly in cancer, MS, inflammatory conditions, rheumatoid arthritis, etc. So, as some background, we're the Health Policy Commission and have tracked costs and spending very carefully. Specialty drugs have represented a fast-growing share of all drug spending. These are U.S. numbers, but we do know that numbers in Massachusetts track very closely to these, growing since 2010 from less than a third of all drug spending to almost half. So getting into the definitions of what we're talking about here, brown and white bagging are a different means of distribution from the traditional practice, or colloquially known as buy and bill. These are when drugs are covered under the patient's medical benefit, which has been the traditional practice, again, because they are infused or injected. In this traditional way, providers purchase the drugs for general use, store them in their pharmacies, and they are reimbursed both for the acquisition and for the administration of the drug. In the Medicare space, reimbursement is based on formula. In the commercial space, reimbursement is again based on negotiations in the same way that other services would be. So what we're talking about here today is an alternate practice where the coverage of drugs is shifted from the medical benefit to the pharmacy benefit. And the the provider is therefore taken out of the acquisition chain. Through two different routes, we have where the drugs are taken from, provided by a specialty pharmacy, and provided for the individual patient as opposed to for general use. The two main channels that we're discussing are white bagging, where the specialty pharmacy ships the drug to the pharmacy for the provider to administer. And then the alternative is brown bagging, where the patient either picks up the drug from the specialty pharmacy themselves or perhaps it's shipped to their home. The patient is therefore responsible for bringing the drug to the provider to be administered. There is a third mode that is doesn't neatly fall under either brown bagging or white bagging, but is closely related and a topic that we hear in conjunction, where payers mandate that the drug is administered at home through a nurse or other provider instead of a hospital or office setting. In this case, the payers reimburse only for the administration of the drug, and not for the drug itself. So among the critical questions are patient access, safety, and cost sharing. We know that different benefits lead to different cost sharing structures, as well as different requirements for utilization management. We do have some flow charts. We love a good graph, but they're a little tricky, so I'm actually gonna skip through them. But if there's any questions, we have these as references. So turning to you, and what we hope to hear today are a number of different questions. How do you define the issue? What is the prevalence of these practices? Prevalence of brown bagging versus white bagging? Which drugs? How many? Trends over time? And again, in particular, the impact on patients, cost sharing, safety, access, and other aspects of the patient experience. Learning more about financial impact, and also hearing any solutions or strategies that have that stakeholders have encountered or would like to see. And with that, I will turn this back over to you so we can go.
Thank you, Sarah. So we'll move to the public comment section. I have a list of folks that have signed up in advance. Again, if you are just joining us and haven't signed up, there's a sign-in sheet that you enter. And then when we have completed all those who signed up, we will ask if there's any other testimony that wishes to be offered. And again, reminding folks that we're limiting the comments to 5 minutes, but certainly we'll take your written comments as well until Friday. First person is Paul Jones, Senior Policy Advisor for Blue Cross Blue Shield of Massachusetts.
Thanks very much for the opportunity to provide comments today. My name is Paul Jones. I'm a Senior Policy Advisor for Blue Cross Blue Shield of Massachusetts. I'm joined this morning by our Director of Clinical Pharmacy, Tom Kowalski. Over the past few years, there's been something of a misperception, I think, of a policy that Blue Cross implemented several years ago, and we're really pleased to be here today to set the record straight. And I really want to stress right from the start that Blue Cross doesn't have any policy that requires the brown bagging of a drug, that requires the white bagging of a drug, or that requires home infusion. Our policy is actually really very simple, but it requires a little bit of background. As you know, specialty drugs continue to increase disproportionate to the rest of the healthcare industry, and as a non-for-profit health plan, it's our responsibility to manage those costs without impacting necessary access to necessary services for our members. In 2015, we found that a billing practice that was being used by some providers of specialty infusion drugs was unnecessarily increasing costs for our members without improving access or quality of the care they received. In short, expensive infusion drugs were being billed, as you said, on the medical benefits instead of the pharmacy benefit at a much higher cost at a greatly inflated rate. For example, a monthly treatment of the infusion drug Remicade normally costs about $5,000 a month when for a month's treatment when billed through our pharmacy benefit. It's an expensive treatment. We had found that some providers were buying and billing this drug and charging us regularly between $20,000 and $28,000 per treatment, 5 to 6 times as much as the specialty pharmacy contracted rate. And it's really important to note, by the way, that fee is for the cost of the drug alone. There is a separately billed and paid fee for the actual administration of the infusion. I think that's a really important note. The aggregate additional cost of this policy to our members and to our accounts is about $20 million a year, just for 3 drugs. And so in response, we informed providers in 2015 that we were going to require that 3 infusion drugs, Remicade, IVIG, and Botox, be billed through the pharmacy benefit. We felt like this was the responsible thing to do, not only for our accounts, but it also limited the cost-sharing exposure for our members. When something is billed through the pharmacy benefit, generally deductible and co-insurance doesn't apply. So the most exposure from a cost-sharing perspective that a member is going to have is about $50 a month for a tier 3 drug. If it's billed through the medical benefit, then there's the potential for thousands of dollars in deductible and co-insurance payments. We built into the process time to get detailed feedback from providers on this policy change, and several providers came to us and said that their IT systems couldn't operationalize this new requirement. We delayed the implementation of the policy and worked with those providers to find new ways to implement it without impacting the patient experience or the ability for providers to be reimbursed. The revised policy went into effect in October of 2015, and it allows Massachusetts providers to continue to buy and bill infusion drugs just as they had before. We prefer that they do so on the pharmacy benefit, but it's not required. The only actual requirement is that they bill at the contracted specialty pharmacy rate. We don't mandate how the provider obtains the drug. We don't mandate how the provider administers the drug. Those decisions are left to the discretion of the provider and the patient. A provider may decide to brown bag a drug to be administered in the office, and in fact, providers choose to do this fairly frequently with specifically with vaccines that have special storage requirements, like the HPV vaccine, the rabies vaccine, and also with injectable contraception, when they often either don't have the storage facility available or they don't want to, for example, buy a 12-pack of a vaccine that they're only going to be administering to one patient. It's important to stress, though, that our policy is agnostic to those decisions. It's a billing change only. We will pay for the drug regardless of how it is obtained or administered, as long as it's billed at the contracted rate. To date, all Massachusetts providers have successfully implemented this new policy and now bill at the contracted rate, and about 85% are still buying and billing just as they had before. About 15% have chosen to process it through a specialty pharmacy network. But we strongly believe that this billing policy is the right thing to do. We worked collaboratively with stakeholders to find a solution that would remove $20 million in unnecessary costs from the system without impacting quality, without impacting access, or without impacting the administration of these important treatments. Thank you again for the opportunity, and Tom and I'd be happy to answer any questions you may have.
So just one question. You mentioned you started with 3 infusion drugs. So is the policy those 3 drugs, or has it been expanded to other?
I think there's a total of 4 or 5, remind me, Tom,
So
it's a short list.
it's those 3 drugs, and then we expanded it by including another drug, for lead-in extra. We allow that to go through both benefits as well. And now recently, there's 2 new biosimilars to Remicade, Inflammatory and Plexus. We'll be adding those into the policy effective on July 1st. So same policy will hold true, either through specialty or through buy and bill, regardless.
I have a whole bunch of questions, so I hope you'll bear with me. By all means, I may put you to sleep before some of these drug papers, obviously.
Fair enough.
So I just want to, I have a bunch of questions in different domains. I just want to first start off by understanding the policy. So I have Blue Cross Blue Shield Medicaid coverage guide here, which has at least 70 drugs which are listed under your coverage for the medications listed in this section is available only through your pharmacy benefits. So what's the distinction between this list and the 3 to 5 that you just mentioned?
So the list of 70 would apply to drugs that are primarily self-infused or taken orally. So those would be self-administered by the patient, such as an Enbrel, Humira, or an orally administered drug like a Xeljanz, like a tablet, something we're taking for rheumatoid arthritis as well. Doesn't apply to those infused drugs like Remicade, IVIG, or Botox.
And is that a new policy, Tom? I don't think it is, right? That's been
No,
in
that
effect for-
policy has been in effect since 2010.
Right.
We blocked a bunch of these self-administered drugs from the medical benefit.
Right. We were focused, I think, Commissioner Cutler, on infusion drugs because it was it changed to the infusion drug policy that seemed to generate this discussion.
So can I just make a list of the drugs you mentioned, just because I have the 70 and then I have another 20 or so, which are medications received at a doctor's office, for which you also want to do. So I guess I have then the subsequent list of about 20 drugs under option 2, medications received at a doctor's office or outpatient hospital. Which is this, how does this list of 20 then compare to the?
And then you said that's the Medicare list?
No, medications received at a doctor's office or outpatient hospital. If you live in Massachusetts, your doctor or outpatient hospital may be able to get your medications listed in this section. Your doctor can order these medications at a retail specialty pharmacy in our network. In addition, your doctor can refer you to a network home infusion therapy provider, but provider authorization is required. So this was right below the list of drugs that have to be through the specialty pharmacy.
Okay. Just could you read me a few of those lists? I just want to make sure I'm.
Bivigam, Botox, Caroline, Dysport, Flebogamma.
So those are all different brand names of IVIG or botulinum toxin. So Dysport is another brand like Botox. Xeomin is another brand of botulinum toxin. Caramune is another brand of IVIG. So we're referring to those therapeutic categories. I apologize.
Got it. Remicade is on this list. And
Correct.
Botox is on this list.
Yes.
So
So yeah, 20 different drugs, but 3 different brand name drugs, 3 different therapeutic categories, correct?
I told you.
Sorry for the confusion.
No. I'm the one who's confused, so I appreciate that. Just as I told you, I have a zillion questions.
No, please.
You had mentioned the cost sharing for the patient. Is it the case that in every single circumstance, a patient's cost sharing is lower if it's on the pharmacy benefit than on the medical benefit?
No, it'll definitely depend on your plan design. If you don't have a deductible, most plans do. If you don't have co-insurance, then those won't be an issue for you and you wouldn't have the $50 a month copay, but it definitely limits the potential exposure for those many members who do have deductibles and co-insurance on the medical benefit.
Can you estimate what share of the members pay less when it's on the pharmacy benefit and what share pay more when it's on the pharmacy benefit?
I think we'd have to follow up.
We'd have to follow up on
Yeah.
that. I don't know the numbers off the top of my head.
I don't know about my colleagues, I personally would find it useful to know
Yeah.
something
Yeah,
about
to do that.
that and about the average savings to the patient and so on. And the average savings when they're savings and the average cost when they're costs.
That would be, I think, hard to do because there's so many different plan designs and to apply the co-insurance, for example, or the different types of, it would depend a lot, frankly, on whether or not you would hit your deductible as well, obviously. So the average savings would be difficult to calculate, but obviously if you have a $2,000 deductible and you go in on January 3rd for an infusion, then you're paying your deductible that day. If you've got 20% co-insurance on top of that, it's going to be that much more. So as opposed to a $50 copay for the drug, your exposure is literally into the thousands of dollars for those who have deductibles and co-insurance.
On the specialty benefit, so you have a separate tier on your pharmacy benefit, you have a separate tier for specialty medication.
Some of our benefits have a separate tier, when they jump to specialty drugs, either to a fourth or a fifth or a sixth tier. Our standard benefit has specialty drugs lumped in with traditional drugs, either at a second tier or a third tier.
So what share of people will have a higher copay through the, do you know what share of people choose the standard where?
It's about 80% of our members have a standard 3-tier benefit, so a second tier or a third tier copay would apply for most brands, whether it be an oral traditional drug or a specialty drug.
So is it your sense that on net you think that patient cost sharing is lower?
That would be my expectation, is when we go back and look at this, that the vendor cost share would be lower, based on the plan designs that people have slotted into.
But not in all cases.
Not in all cases, correct.
I'm not holding that as a standard. That
No,
is- that is-
absolutely,
Any benefit change is going to have some people who benefit, some who
absolutely.
don't benefit. So the standard in benefit changes cannot be every single human being in all states of the world is
No,
better off.
Right.
No,
But I'm just trying to understand what the nature of it is.
yeah, vast majority would be in standard
Yeah.
3-tier copay.
I mean, I would say most of our plans have a deductible. And so if you're assuming that you're going to be meeting your deductible, like I said, even a $2,000 deductible would be 3+ times a 12 months of a $50 copay. So one patient that had a deductible would be paying more than 3 times the cost sharing just for the deductible than a patient with
Yeah,
$50
It's
on the
tricky
copay.
it's tricky because my guess is that most of the patients who have a deductible are going to exceed the deductible independent of this expense.
It is tricky.
So,
It is
so
tricky.
even though the $2,000 may go towards this medication,
Right.
if it didn't go towards this medication, it would have gone towards something else. So that the under the medical benefit, the cost would be not the deductible cost, but if there's any co-insurance.
And any co-insurance could be really significant, especially when we were being billed $20,000 and $28,000 for these $5,000 drugs.
So my first line of questioning was about the patient, or I guess my first was about trying to understand these 2 pages, which I now do. Then I wanted to ask you about the patient rate cost sharing. I want to go in at least 2 other lines of questioning. If I may. Do you have a sense about how much this has affected your specialty pharmacy bill in total?
Like I said, it's the 3 drugs that I mentioned, Remicade, IV, IgM, Botox. We're saving about $20 million a year in excess cost compared to before the implementation.
And what do I divide? What's a thing that I would divide that by to figure out some percentage?
So our our total drug spend on an annual basis is in the neighborhood, on pharmacy is in the neighborhood of 1.4 billion.
Yeah.
And specialty, you're
That's
talking,
all pharmacy.
yeah, and that's all pharmacy, so specialty, you're talking half, so you're looking at 700 to 800 million on specialty. So, single digit percentages.
And for these three to 5 drugs, it's probably, you think you've cut it by 2/3?
I would say that $20 million in savings is probably about 5% savings across the spend, it's about 5 to 10% across all of them spending upon
Why is it that small?
Because it's a small population that are using these drugs.
And not everybody was necessarily using this billing practice.
I see, so the example of the 25,000 is a very high outlier.
Yes. Yes.
Yes, and that was definitely the high end. But it's, I think, also true to say that not everybody who was administering these drugs was buying and billing it. Like I said, there were some providers that were increasing the cost at those rates, but it was certainly not all providers. So that's why you wouldn't see a 5 to 10%. It's not as though every bill that we're getting is being reduced by that much.
But just to be clear, if it's falling by 5 to 10%, so that means that relative to the, say, 5,000 a month you're currently paying, the amount that you were paying on average was 5,500, something like that, right? Because that would be a 10% saving. That's roughly a 10% savings, 5 to 10% savings. I mean, I understand.
Yeah, I see where you're going with that. That's what you're going with.
Yeah,
So, and on average, I would say, so that my calculations are wrong, so I would say that anywhere between, it's a $5,000 and $10,000, what we're seeing on average, those bills, 5,000 is the lower end of the spectrum, 10,000 is probably in that range, and then there was that outlier of folks in that 20 to 28 million, the smaller percentage.
We'd have to follow up. We're sort of doing this back of the envelope as we're talking, so we're happy to follow up with you on more concrete numbers on that.
I think, I think it would just be helpful for us as we think about the scope of the issue that the legislature has asked.
Absolutely.
Are there any changes in facility fee payments that result from this practice, or is all the savings on the acquisition cost of the medications?
It was on drug.
Yeah, this is solely on the drug. There's no change at all to the, I mean, we generally don't pay facility fees, but as far as the fee to administer, the clinical fee to administer the drug, that's entirely separate and hasn't been changed at all.
Okay, so it's entirely on the.
Yeah, this is entirely for acting as a middleman, buying and billing the drug.
Do you do home infusion of these drugs?
We have a home infusion benefit, absolutely.
Do you encourage that when the patients are doing the white and the brown bag? Particularly brown bag?
We make that as an option. Yeah, so if it's appropriate, and if the patient wants to do that, yeah, we'll help them get to that, but we don't force them one way or another.
Do you observe more of that happening when you do the brown bag?
Commissioner, when you say when you do the brown bagging, I just want to make sure we're on the same page and understand quickly.
No, I would say no, not on the brown bagging, where a patient's actually bringing it. It's generally when the home infusion is done, it's being delivered by a home infusion vendor specifically. It's acting as a pharmacy, so they'll deliver the drug along with either a nurse to help set it up or to show the patient how to use it. And then after that, they'll just schedule deliveries of the drug to the patient after they've been taught how to do that.
So I'm not surprised you learned that the AMA is concerned about the safety of this.
No, absolutely.
Have you, so I have two safety related questions. One is, have you had anyone complain to the plan about a specific safety issue, like someone who actually said, okay, this drug turned out to be not safe because of X, Y, or Z, which was attributed to either white bagging or brown bagging? And then my second question is, have you done internally any studies associated with, are there any impacts, favorable or unfavorable, on patient adherence to medications when done through white bagging or brown bagging in comparison to buy and bill?
I mean, I think it's important to reiterate, Commissioner Cutler, that our policy is agnostic to whether a drug is brown bag, white bagged, or bought and billed. That's the past tense. So I don't, I mean, Tom, correct me if I'm wrong, I don't know that we've looked into it directly because that's, as I said, we leave that to the discretion of the provider and the patient.
And we haven't looked at adherence, whether it's better or worse with respect to brown bagging or white bagging. terms of a safety issue, the only time I've ever seen that come up is hesitancy is when somebody's starting therapy for the first time. They don't want to do it at home. They're not sure how a patient's going to react. They would prefer to do it in a facility or in the physician's office to see how there's a reaction. Or the only other time that I've heard pushback is if it's on a pediatric patient. Just for various reasons, whether it's hard to either find a vein or the child is difficult, or it's just a circumstance where the parents don't want to create the home environment as a place where the child associates with having an infusion or some sort of condition. They want to try to keep that home place more normal, so they prefer to do it at a infusion clinic or at the office where it puts less stress on the home life for a child. But aside from that, those are the only few circumstances that I can push back on from a clinical perspective.
The reason why I was asking about the safety issues, if I recall your statement correctly, you said, if I understand what you're saying, you said, okay, look, we're only going to pay $5,000. How much of you have been billing over $5,000? We can acquire this drug for $5,000, so therefore that's what we're going to pay. You, provider, can decide, do you want to buy it, for which we'll pay you the $5,000, or do you want the patient to buy it through the specialty pharmacy, in which case then the $5,000 flows that way and not through you. And so then if I understood you correctly, what you said is 85% of the providers chose to continue with the buy and bill, just accepting the lower fee, and 15% said, look, we don't want to do this anymore, we're going to have the patient order it through or we're going to order it through Wayback.
Some of that 15% is processed through an in-house specialty pharmacy. So an acute care hospital that has a specialty pharmacy in the building.
I see.
That would count as part of that 15%.
I see.
Right on. Correct.
So the true number for which there is actually a change in how the medication is provided is less than 15%.
In reality, yeah, because in reality, it's going through either the hospital providing it through their intake, the hospital that's on the inside of the pharmacy, or the hospital, or the pharmacy that's on the kind of outside of the pharmacy. So yes.
So the 15%. So if you say what share of patients actually have a change in the nature of how they're getting the medication, would that be somewhere between 0 and 15%?
Yes.
Do you have a sense what that would be?
It was probably a smaller percentage, probably single digits, probably about half of that when we first started, and then it's doubled up to about 15%. So an increase of probably about 50-fold or 50%.
So it's now probably about 15%.
Yeah.
So that's the 15% for which one would want to know whether there are issues associated with adherence or the availability of medicine in a timely fashion or anything. But you say you haven't done any studies of that.
I haven't done the studies, and any of the issues that would have come across from either the members or providers would have come across my desk or
Right.
From the
Received few, if any, complaints from providers since that initial round back in 2015, where we worked with them on some logistical issues. It's been very, very quiet as far as any complaints go about the policy, at least directly to us.
And from patients.
Not aside from the couple of conditions that I mentioned previously, there hasn't been anything that's come across my desk that sticks out significantly in terms of member having access or clinical concern outside of what I mentioned.
Is there, this is not, please do this, I'm just asking, is there a way that one, if it were deemed appropriate, one could do a study to look at adherence among those patients?
We probably could, although with injectable, it's a little bit more difficult because of changing doses and frequency, whether it be 6 weeks or 8 weeks, right? But yeah, we could certainly do it. I don't see why it would be a great deal of faith difficult in terms of kind of pulling data to try to figure it out. So we haven't done it.
I mean, some of the questions I asked were just factual questions, and they're just
sure.
things that you can go and tabulate and so on. This one, like if the legislature were sufficiently concerned, if there were conflicting views about the safety, that I'm exploring avenues that they could ask for. That would then say, is there a way to shed light on this, and if so?
I don't think it's an unreasonable request for us to do or to do that, so I don't think that it's difficult, it's just we haven't done it, so I guess
And I think especially for white bagging, even that should be really invisible to the patient.
Yes.
I
I think that's right, but but you hear stories about, you can't switch dosages at the last moment, and you can't go up, and there, and so, has this in any way interfered with
Right.
the flexibility that a provider needs?
Again, we leave those decisions entirely up to the provider. They're welcome to continue to buy and bill.
No, I understand, but suppose
Right.
they've chosen the other way.
Right.
Suppose they've chosen the other way for some reason, then the question is, does that?
No, understood. That's understood.
I'm not saying it's your fault, I'm just trying to
Right.
say, is there a possibility that the system leads to worse outcome for some
Yeah,
patients?
yeah.
And if
Certainly
so,
something we could look into.
and if so, that would be relevant information for the legislature to think about.
That's helpful.
Yeah, and with a specialty pharmacy located either in that facility that is contracted with this, or it's an outside specialty pharmacy, we generally have service level agreements and requirements, PGAs, that they, once contacted, they have 4 hours to deliver, so there's a very tight turnaround in trying to assess some of those changes in doses that may occur, or scheduling or changes in schedule that may have to occur based on that change in dose.
Are you seeing a change in waste on these 4 medications? Either return medications or medications that end up not being used?
I have not, no.
If you're in there, you're gonna prosecute me for badgering. So maybe that I should stop here, but Sarah.
We're happy to have this conversation.
But Sarah, I haven't given you a chance to ask questions.
Tom and Paul, thank you very much. Our next witness is Sylvia Bartel, Vice President of Pharmacy for Dana-Farber Cancer Institute. Welcome. Again, 5 minutes.
Good morning, commissioners. In addition to my role at Dana-Farber, both as the Vice President of Pharmacy and I chair the Pharmacy and Therapeutics Committee, I have over 25 years of clinical pharmacy experience specializing in oncology, and I currently serve on the Commonwealth's Pharmacy Advisory Committee within the Massachusetts Board of Registration in Pharmacy. On behalf of Dana-Farber, I appreciate the opportunity to comment on significant patient safety concerns associated with the practices of brown and white bagging. We'd like to thank the HPC for further examining these concerning practices and appreciate that the HPC staff have reached to us along the way in order to better understand the patient safety issues. As you know, these practices are an evolving pharmacy trend among certain health plans and could significantly change the way we provide medications to our patients. This raises significant patient safety concerns for a subset of supportive care drugs used for oncology patients, non-self-injectable medications. These medications must be administered by a licensed clinician and are not in ready-to-use form, but often must be aseptically manipulated in a clean room and compounded for an individual patient based on their health status and lab results on the day of administration. This requires rigorous quality and safety protocols. Specifically, the concerns associated with these practices include chain of custody or drug integrity, the integrity of the effective prescription drugs, which have specific handling, storage, and temperature control requirements, may be compromised while in the custody of a patient. Documentation in the medical record. Brown bagging precludes the provider care team from having a complete record of drugs administered to the patient, which includes information such as the expiration date, drug-specific lot numbers, documentation of side effects, adverse reactions for medication recalls, etc. Patient confusion. Brown bagging policies confuse patients who may not understand where or how to get their medication at a specialty pharmacy, which increases the risk of missed or delayed doses. Supply and drug waste. Specialty pharmacies typically dispense a 3-month supply of patient-specific medication, which may exceed the intended number of doses for treatment. As a result, a patient may continue to receive treatment when the medication has either been discontinued or the intended number of doses has been administered. This can also result in an increase in drug waste. In addition, as part of Dana-Farber's rigorous quality and safety protocols, We typically batch order medications at a volume we anticipate necessary to accommodate all of our in-clinic patients. When drugs are brown or white bagged, an individual dose of injectable medication arrives labeled for a specific patient. This subverts our unique and specialized pharmacy systems, which incorporate state-of-the-art safety features that Dana-Farber has spent years developing. These systems simply cannot safely accept drugs and manage inventory for an individual patient from a third-party specialty pharmacy that is outside of our typical distributors. Given the complex medication regimens and toxicity of the treatments required by our oncology patient population, this threatens to compromise the safety and integrity of our patient care. As a result of these concerns, Dana-Farber has elected not to accept any brown or white bag medications from patients or external pharmacies. Regarding your question about how widespread these practices are, we cannot comment because we do not allow them. We have continued to follow our policies and safety procedures when dispensing medications to our in-clinic patients. This has required us to obtain patient-specific waivers to ensure we can continue providing these drugs in a hospital clinic setting. We maintain concerns that brown and white bagging policies are emerging market trends that may become more widely adopted and or may evolve into policies that restrict access to these drugs entirely, as has been done in other markets. In response to your question about how many and which specific drugs have shifted, there's not a fixed list and it varies by health plan. While drugs are increasingly being transferred to the pharmacy benefit, it is important to note that we are only concerned with the specific subset of these drugs based on the profile of the medication and the patient's clinical condition. One example is IVIG, immune globulin, that is used to strengthen the body's immune system to lower the risk of infection in persons with a weakened immune system. It is routinely used for patients with hematologic malignancies and with post-bone marrow transplant patients. These represent one of the sickest oncology patient profiles. Even though IVIG therapy has been around for some time, there are several key considerations to ensure safe, effective patient outcomes. These include product selection. There are several IVIG formulations available, and each may cause different side effects. Switching between formulations is not recommended. Adverse reactions. There is the risk of serious adverse reactions, including severe allergic reactions, as well as some more common side effects such as fever, chills, that require patient monitoring. Complete documentation of patient monitoring, adverse drug reactions experienced, and the IVIG formulation administered is critical to avoid clinical consequences for the patient. This is especially important for cancer patients that have recently undergone a bone marrow transplant. If IVIG is supplied by an outside pharmacy, this critical information will not be captured, causing a gap in the medical record. Brown and white bagging also negatively impacts the patient experience from a financial perspective, as well as causing possible delays in treatment. When drugs are moved from the medical benefit to the pharmacy benefit, patients often pay for a percentage of the total cost of the drug as opposed to a flat fee. For many patients who already face a number of financial burdens, this results in a significant additional out-of-pocket cost. Patients may also experience a delay in treatment as a result of the patient waiting for the medication to arrive from an outside pharmacy instead of receiving the medication in clinic. In addition, we believe that brown and white bagging constitute redispensing, which is prohibited practice in accordance with the Mass Board of Registration and Pharmacy regulations, and should therefore not be permitted on the basis of these existing state regulations. In closing, I want to emphasize that these are incredibly complex and important issues, which truly warrant a regulatory response to ensure that pharmacy regulations keep pace in protecting patients. Our hope and recommendation is for the Department of Public Health and the Board of Registration and Pharmacy to take regulatory action to prohibit and or curb these unsafe pharmacy practices. Thank you for the opportunity to provide testimony on this important patient safety issue.
Thank you, Celia. Make sure we get the written testimony as well.
Yes.
You mentioned patient-specific waivers. Do you have a number or a percent of patients that you've sought those waivers for?
Yes, and I don't have a specific number with me, but we can get that for you.
That'd be helpful.
What do you need the waivers? Can you explain what you need the waivers for?
I would need to get back to you on that question, but the waiver is really to allow us to administer the medication in clinic.
To administer the medication,
Medication in the clinic.
meaning if the patient purchased it
Yes.
or obtained it on their own.
Yep. So it allows us to maintain our standard practices where we purchase the drug, dispense the drug, administer the drug in the clinic.
So this is for a drug where you haven't done it in your, where you are not the provider, you haven't done the buy and bill.
If the payer is requiring that we
Oh,
aren't allowed to
required.
do the buy and bill, our An interim solution is to request a waiver so that we're allowed to provide the care to the patient as we would regularly.
May I also ask you a whole bunch of other questions, again, just because I'm trying to learn? That was about as rapid a presentation as I could imagine.
I tried to stay within my time.
I may ask you to repeat things you already
That's okay.
said.
I'm happy to.
Do you have, are there any insurers that require white or brown bagging that you deal with? So Blue Cross Blue Shield said they don't require it. Yeah, but do you work with some insurers that do require it?
The trend and the evolving trend that we're seeing is that there are what we've termed the interim solutions. So I'm not familiar with all of the plans that we deal with. My focus is really from the patient safety pharmacy perspective. So I'm happy to get more specifics if we go through all of our plans.
I mean, I could well believe there are some, I don't know of any, nothing's been brought to our attention about plans with large enrollments in Massachusetts that require it, but you may also be dealing with plans that are far beyond Massachusetts, given the nature of Dana-Farber. So I think if there are any, it would be good to know. It's also not clear whether, in fact, I don't know whether we can attach requirements to plans outside of Massachusetts in terms of what they require with respect to policy versus medical benefits. I just don't know the answer to that.
Right. And it's, as I mentioned in my testimony, it's a little challenging for us because we've not allowed this practice.
Yeah.
So even going back to 2010 in our history.
So you're one of the 85% of providers, according to Blue Cross Blue Shield, you're one of the 85% of providers that have chosen to just continue with the buy and bill but at the lower rate. Has that been harmful to Dana-Farber patients?
So I think from a patient safety issue perspective, it has not, because we're able to obtain the drug through the buy and bill model. I think that as we work with each health plan, there are administrative burdens that are associated with that. And again, I apologize, I don't have the specifics on that information, but we can get that from you. But from a patient perspective, safety perspective, no, because we followed our standards practices, which we always have.
And I'm not going to ask you to name names, but do you, is there folklore among your colleagues that there are some institutions that are very concerned about the safety because they aren't able to do what you're doing, and so therefore, is there a significant safety problem associated with these policies in Massachusetts that we should be worried about, or is it more of a kind of potential if this moves broadly and we say you cannot buy it?
When I've spoken to my colleagues about these practices, they all raise the same safety concerns that I've raised.
But the ones you've raised are more from your institution perspective, are more potential.
Yes, correct.
Because you've chosen.
Because we've chosen not to.
You've chosen not to do it in one way. Do you hear about cases where it's not just potential, where it's actual, where the providers say, in Massachusetts, where they say, I'm being forced to do this, and it's not good for the patients. I believe my patients currently are suffering.
I just know in talking to my colleagues that I don't have a particular case that I can say someone, said that this was what they weren't going to do with safety. But I think everybody feels that concern. Clearly, with some of these drugs that are not intended for self-administration. So it's really that subset of drugs that we're concerned.
The list that we were talking about earlier, that's also the same as your list. I mean, you mentioned the IVIG ones are the biggest ones. So you still, for all your patients, or essentially all your patients, you still acquire them in your own pharmacy and
yes,
mix them and supervise them as appropriate.
Yes.
Is it correct that so far the biggest impact on Dana-Farber has been a financial impact? That it's cut the reimbursement rate a fair amount for the medications.
It's cut to the reimbursement rate, but there was a time before when we didn't have that option. This is an evolving practice. So were there times that we did not receive payment for those drugs? Yes. And we've, again, because we've made the choice to continue with our current safety protocols, it hasn't impacted patient safety.
So from your perspective, and yours now is sort of two parts. There's you as the Dana-Farber, and there's you as someone who looks at, and as working on the pulse of clinical safety of particular oncology patients throughout the Commonwealth, obviously the nation too, but we're in charge of the Commonwealth. The most important, am I correct that the most important thing would be if the legislature wanted to weigh in, is the most important thing that providers have the right to do buy and bill at the pharmacy price? Buy and bill at the pharmacy price. That is, they can't be prohibited from doing that. Is that the most important issue?
I think for us, the most important issue is that we're able to determine which drugs those that are not safe based on the drug and the patient's clinical condition, that those drugs are allowed to be under the medical benefit, the buy and bill model, and that we are not asked to redispense or not understand the chain of custody and have a complete medical record.
In my mind, I may be trying to make a distinction between two things. I can't make a distinction between. One is whether the benefit is a medical benefit or a pharmacy benefit, and the second is whether the drug is acquired by you or done through your internal processes versus external. And I think of those as two different things. From the patient safety point of view, it doesn't matter whether it's a medical benefit or a pharmacy benefit as long as it's done.
Yes.
Require and so on. So from the safety and integrity of the drugs, what you care enormously about is, do you have chain of command of possession over the drugs?
Right.
And that may or may not be ancillary. That may or may not be synonymous with it being a medical benefit or a pharmacy benefit. I mean, I would imagine to a first approximation, you don't care where it is.
From a safety perspective.
From a safety perspective.
What happens with a patient who wants to do in-home infusion?
So if it's appropriate for the patient to do in-home infusion, we would work through that depending on the drug and again the patient's clinical condition.
But again,
And having the
no
and then,
pharmacy.
yeah, and then making sure that the medical record integrity is tracked, because especially important for our patients is to have a complete medical record so we know how many doses they received, the timing of the doses, etc. What the patient's laboratory diagnostic results are at the time of administration. So if we can accomplish that, and it's determined by the clinical team that it's safe to do in the home, we will do that.
And that will be done with Dana-Farber personnel or through someone that you're contracting with directly or
Through someone right now, through someone we contract with.
Have you experienced complaints from patients? I'm asking about a series of complaints you might have received. Have you experienced complaints from patients about cost sharing associated with moving drugs from the medical benefit to the pharmacy benefit?
I would have to get back to you on that. I'm not aware of what's that patient financial side.
I think if there were some number of patients who said, "Oh my gosh, my price for this drug just went up a lot, and I'm not sure I can afford to take it," I think that's a really serious issue.
Yes.
Have your
So we can get that
Yeah.
information.
has it affected do you have complaints from clinicians about any of it?
Again, from our clinicians, because we really don't,
It hasn't.
it hasn't really reached the
Yeah.
clinician. It had, as we start fragmenting the medical record and doing things like that, yes.
Yeah.
We would. And our physicians were part of our decision when we wrote our policies to not accept round and white banging. And so many of these safety features are driven from the medical oncologist directly.
Do you know how big a financial hit it's been to the Dana department?
I don't have that answer for you, but again, we can get that for you and get you a number.
I mean, I'm not saying that's either good or bad, just.
No, just what the number is.
It's just
Yeah.
like,
Yeah.
it's clear that Blue Cross said it saves us money. And the counterpart, my old friend, Ray Reinhardt used to say, one person saving money is another person's lost revenue.
Right.
And so I'm sort of curious about like how big it's
Yeah,
this
and
is
we
for the
can,
various institutions.
Yeah, and we can get you that.
Yeah.
number.
What about the issue of wastage? I guess since you've chosen to do it all internally, that's not a particularly big issue.
Correct.
I suppose it may only be an issue where you're forced to do it. So if you could tell us, not the second, which insurers are forcing you to do white bagging or brown bagging, that would be something that would be valuable for us to know. Like, where is it voluntary and you've chosen to do it the way that you believe is best? And where is it mandatory in a way that's contrary to what you think is good for the patient? It seems like that's a valuable thing for the legislature, for the public to know.
You mentioned a concern about the weight that for the drug that a patient might face. I understand that you don't do this practice, but in detailing your concern, could you talk more about what that might look like? How long might the wait typically be?
So in my understanding, and I know through drugs that go through the specialty pharmacies, there's often a prior authorization process. And sometimes that process can be prolonged depending on the type of drug. So if the clinician would like the patient to start today and it requires a prior auth, we may not be able to obtain that on that day. And so it could be days, depending on the drug, the plan, and the patient's circumstance.
If it weren't for the prior auth and it was just a matter of transportation, would that be, would you be able to obtain a drug on the same day?
I think if it in a brown bagging situation or white bagging, probably not same day, just because it's coming from outside, but if it's not coming from the regular distribution channel. If we were to think about accepting a practice like that, which we wouldn't, but there would be delays, they wouldn't be able to get it on that same day. Thank you very much.
Our next witness is David Twitchell, Chief Pharmacy Officer from BMC Health System.
Morning, Commissioners. Thanks for having me. As you said, I'm David Twitchell. I'm the Chief Pharmacy Officer for the BMC Health System. The health system consists of, for background, our hospital, in addition to the hospital, which is a 498-bed safety net hospital, health plan. And BMCHP is a Medicaid provider, largely Medicaid exchange patients. We care for about 420,000 members. Our system also includes a specialty pharmacy, so we cross alluded to people with interior pharmacies. We're one of them at the very least. And that pharmacy not only provides service for BMC, but also 30 other providers in the state, 8,000 patients who receive specialty pharmacy services through our specialty pharmacy. We're very proud of the fact that our pharmacy, in fact, has achieved kind of unparalleled outcomes in hepatitis C, HIV, some other disease states that are difficult to treat, or difficult to treat patients who face difficult circumstances. Our pharmacy was actually recently recognized as the Massachusetts Society of Health System Pharmacists Pharmacy of the Year. That related to something that related to specialty pharmacy around readmissions. I think my position overseeing both the high quality administration, safe administration of drugs in the hospital setting, as well as making sure that the same is applied to all of our 420,000 members, puts me in a unique position to answer some of the questions that you have today. For me, I'm convinced white bagging can be safe and is safe. We use it safely today in both our hospital and our health plan. Our pharmacy, for perspective, fills about 800 prescriptions a month. 200 of those go to Boston Medical Center, about 600 go to providers outside of our own system. We're sought after because we've produced high quality outcomes. We won contracts as well as access to drugs because we've been able to show that we can better than the alternatives, which is often retail pharmacies versus an open network, but is sometimes providers as well. We do that by ensuring that there's safe systems in place. So logistics, cold chain, overnight delivery or courier systems for same-day delivery when these types of issues come up. We also work with our providers, and I mentioned there's over 30 of them, where there may be circumstances where it's difficult. We work with them to decide we have systems in place that they're comfortable with how the drugs are being delivered to their system. I would also mention that these standards are a core part of specialty pharmacy. So specialty pharmacy, as Sylvia and others have said, is an emerging practice. It's kind of 2011 on has grown tremendously, both in how it's spent and how it's organized. And these are things that we think are fundamental to our practice. I also think we probably should consider implementing easy to follow regulations that would set some standards and that we wouldn't have variations. We think we do a good job, perhaps others do not. I wanted to go over some of the benefits of white bagging. We've heard a little bit about some of the pitfalls that we can face. I think those are real. I think, first of all, they do lower the cost of healthcare. Blue Cross Blue Shield colleagues mentioned this. My example is Lydell. It's a long-acting drug that we white bag. Both we receive it in white bagging and we do it as a specialty pharmacy. Again, the cost under the buy and bill is over $4,000 per month per patient, and that is a consistent charge that we get, and it's a contracted rate of the fee schedule versus about $1,000 a month for the same exact drug every month. That's per patient in the Commonwealth. That would be a $36,000 a year difference plus every year for every patient. Considering the opioid crisis, there's a growing number of people on this. We have a large number of these patients in our own system and in the systems that in our ACO and others that we serve. I also think that in most cases, white bagging creates faster access. So you've heard a little bit about prior authorizations or PAs. That happens on the medical benefit as well. And we did do some studies, not specifically white bagging versus not, but before a specialty pharmacy solution, our average time to a prior authorization being accepted and the patient having their medication in oncology was 11 days. Now, most of them got drugs the first day. There was a long tail on that distribution that meant many people took 30, 45 days or longer. This is for patients that have months to live. Vulnerable patients that have no access to resources and other things that others in the Commonwealth do. We've reduced that to an average of 1 day. And that specialty pharmacy was essentially because people focus on doing PAs that do nothing but PAs, as opposed to a provider and our physicians, great physicians at the BFC, taking care of oncology patients, but the PAs and insurance people are they're a real strong affinity for that. I also think, for providers, we do consolidate reporting on drugs. We are able to watch and make sure that patients are taking their medication, which alludes to the question that you had. We feel that we produce much better adherence. Maybe not, I don't think I have examples of infusion drugs, but we could look at perhaps something happened in the last year when I was gone. But we certainly have shown better adherence in specialty pharmacy rather than typical one. I spoke about HIV. We showed a medication possession rate, which is an analog or an analogy for medication adherence, in our HIV patients of about 70% using community pharmacies. This is for over 800 HIV patients. We enrolled in our specialty pharmacy program. We have liaisons with other resources to take care of them. That is now 95% for all 800 patients. There's a distinct and measurable difference in adherence. Now, there are advantages. There are also challenges, and I admit there are challenges. On the hospital side, we don't prefer to get white bagging. We'd rather do buy and bill. But I think, Commissioner Cutler, you alluded to it, is mostly a financially driven decision because we are able to get the drug from the specialty pharmacies. We've set up systems on the hospital side to receive those safely through either our pharmacy channel or directly to the clinic, because we have people dedicated in each of the care areas whose responsibility includes medication safety, medication delivery, medication adherence. That includes the rare times, and we'll talk about how often it happens, perhaps the questions, when we have to receive the drug via a white bagging channel. So if it does, we have a person assigned to receiving that drug, evaluating whether it arrives safely within temperature ranges that are acceptable. They then store it safely and make sure that it's available. They also coordinate with the patient on their appointment to make sure it's there when the appointment happens to them today. They show up that the drug's not there, that type of issue. I think that's it. Making sure to this point. I do want to touch on brown bagging. I think that is much different than white bagging. Brown bagging, there are no safety protocols that I can put into place to ensure that a patient does not put their drug that's temperature sensitive in their glove box and it's getting exposed to 220 degrees. I don't know what they do with the drug. I've certainly seen instances in my experience of changed the drug that was supposed to be in the vial, and then it was administered in the clinic, and the patient suffered that outcome. So I do not think brown bagging is in the same category as white bagging. I do feel like there's some regulatory action that benefited citizens of the Commonwealth. I think we have to be careful about how many of those regulations go into place, because there are patient rights issues around the ability to use oral medication, self-administration, within the emergency department, to make sure that there's appropriate avenues for patients to get their medications, but also some safety protections in place.
David, your 420,000 lives that you're covering, any evidence of patient safety that's bubbling up to you around these issues, or also the waste question?
Yeah. So I don't have any evidence of the drugs that we select to lay back having any safety concerns. From a waste perspective, there is some waste that is created by this. If I'll use my Vivitrol example, if a patient doesn't show up for the Vivitrol, then it is true that we have to waste that drug. The waste cost is far less than the cost advantages to the plan. That does happen.
Is that a scientific statement that the waste costs are less? Like, as in you've done an analysis?
We've not done an analysis, but certainly on Vivitrol we paid close attention to that. So perhaps in a very narrow example, and in the Vivitrol example, we have definitely done an example. Waste is less than 1 in 10. I don't think it's even that much. I think it's in single-digit percentages versus a 70% savings on a per dose basis.
Just to follow this up, if you were able to provide some of that information to us, that I would personally find that useful.
Yes.
I may be the only human being that.
Yeah.
So I guess you have a couple of different points of view. You have the sort of specialty pharmacy point of view, as well as the sort of provider point of view. So can I ask about the specialty pharmacy part first? Sure. Are you ever required to do brown bagging? I mean, to send to a patient?
No. Our specialty pharmacy does not have any instance where we send the drug to a patient and then subsequently be brought into an office. Now, I think the Blue Cross Blue Shield alluded to, if the patients then go to their provider, say a private physician clinic, and say, I'm not comfortable doing this, could you help me or show me how to do a Humira injection the first time? That may happen unbeknownst to me, but there's no plan that we are contracted with that requires brown bagging as an example.
And there are no plans that you've turned down because they would have forced you to do brown bagging and you felt like you couldn't in good conscience do that.
That is true, but I'll admit that our specialty pharmacy, Cornerstone Health, has limited contracts, so we don't get exposure. We still have the same experience that not all the payers are being exposed to. We do, and I'll skip around. You're concentrating on specialty. On the provider side, we do have instances where I'm not going to be able to give you specific examples now of where insurance, certain plans are asking patients to do a brown bag process, and we do not allow it.
Are those Massachusetts plans that are asking patients?
I can't recall. I suspect they are because 85% of our payers are either Medicaid or Medicare, and our local and our catchment area is Suffolk County. So,
if you had some way of knowing which ones?
I think there is a way to know how to give you that one way or the other.
Okay.
But we don't know. Okay. But certainly I've gotten a call like this patient's being forced to do this, so we do not do that. We'll do anything else, including giving the drug for free, as opposed to taking something outside.
My sentiment is like yours, that white and brown bagging are two very different phenomena. And one needs to be very careful. One does want to lump them together, they may have different implications. How do you,
Can I ask you to move the microphone closer to you?
Sure, I hate the sound of my voice too.
how do you determine which drugs to white bag?
So we, and you'll forgive my 4 weeks in with the plan and back from my 1 year vacation, as they called it. We select drugs that are appropriate, that are not dose adjusted at the time. I think Sylvia actually had some very good points, things that, as is the MHA on some of their points. If there's a drug, for example, that needs to be adjusted based on lab results that day, that is not weight bagged. So we try to find drugs where doses are consistent, and I'll use my one example of Vivitrol in this example. It is a single dose drug. It is given once somebody is stabilized on it, and it is given on a regular basis. So it's a predictable schedule. It's not dose adjusted at the moment, and it lends itself to a specialty pharmacy solution. Other drugs that fit into that category are drugs that we've selected as planned to use as weight bag.
One of the examples that Sylvia gave was IVIG, which I'm going to look at Sylvia to see which way she nods her head, which she thought was not appropriate for white bagging because, here's where my lack of medicine is going to kill me, because the dosage is just very difficult and the timing and so on. In the testing. Do you white bag IVIG?
There is a subcutaneous IVIG formulation that we white bag from our plan. However, not all IVIG and not for all indications. Other plans can have other policies around that, but we believe that there are consistent doses. And in some cases, it is not true that you need lab-specific response. There's no evidence to support a dose change based on what happens that day. There's consistent dose. People often stabilize on this drug. Again, your initial start may not be appropriate for this, but those are all designed to accommodate those things. And these are the types of things that kind of sensible regulations would allow to say these are the circumstances where it's acceptable, and here are circumstances like some that you brought up where it wouldn't be.
So it's possible, although not for sure, that you and Sylvia would disagree about some of your practices.
That's right.
But we have to go into much more detail.
That's right. I think it's on the margins that we disagree, not on fundamentals. She has run a very great program there, and obviously a fantastic institution. I don't disagree with most of what she says, just subtle points.
I've determined you're trying to copy her because she spoke at 800 miles an hour, you spoke at 770 miles an hour. So therefore, I concluded that there was something about her that you thought was worth emulating.
Maybe pharmacy personality.
Yes, you think it's broader than this.
Yes.
You mentioned you think the legislature should possibly have to look at certain types of regulations. Are there categories of regulations that you think it would be appropriate for the legislature to look at?
Or more specific policies.
More specific, thank you.
Yeah, I think policies that reflect some of the quality standards that I mentioned on standards of specialty pharmacy practice. There's some organizations that set standards. There's accreditation organizations. And I've seen other Massachusetts regulations that reflect standards or accreditation standards. And I think that's a good format. In our sterile compounding example, there are standards that are there, and Joint Commission standards that be reflected in pharmacy practice for distribution of drugs. I don't know legislative form that well, but that.
No, but forget about the legislative form. I don't understand it either.
Okay.
Nor do I understand legislation for that matter. If there were a list of the topic areas you think would be appropriate for legislation to look at in terms of regulation,
We have
you could just shoot us something saying, hey, look, here are the 5 areas that we think are most important.
We would be happy to, and they reflect some of my comments, like some form of cold chain logistics safety mechanism, some form of same-day delivery options in the instance where things have changed, which we do have, which, by the way, would exclude some out-of-state specialty pharmacies, which don't do it for us, and we have to get waivers, which really is a waiver for us to buy and build to actually use the drug. But that's only where they can't get it, and there's an emergency where we can override.
Are there some things for which you as a provider do not accept white bag medications?
There's nothing that has been required of us, and there are Massachusetts-based insurers that require us to do white bagging that we have refused on a safety basis. I cannot think of an example. I will check, but I can't think of an example where we said, no, that's a drug, like an oncology drug that is dose-dependent or something that we've had to repair in a sterile prep. We wouldn't accept those, but we've never been required to do so.
Can you give us a list of the insurers that require you to do white bagging for
Yes.
and what medications?
Yep. I actually had an example in my comments that I skipped over because of my miles per hour.
How could you possibly have?
It was so Remicade is a drug that we are required to do via white bagging for patients, and it's actually I'll have to get the insurer, but the PBM it's often not driven by the insurer. We have to remember the payer, the sponsor,
Yeah.
And this is true of CHP uses a PBM, and the pharmacy benefit manager defines that. Caremark, CVS Caremark requires white bagging in many of their plans and many of their plan designs, and Remicade is the drug that they do, And that's where we use that mechanism of, so we've arranged with CVS Specialty in Pennsylvania to mail to particular individuals, those individuals responsible to take the drugs. The plan sponsors that use CVS Caremark, I have to go back to find them.
But it's not a large share that you're required.
It is not. I think, as I asked my Bob Esch's director of oncology, he oversees the infusion suite. There's about 9 patients. His estimation, that's an estimate right now. And, we have 40 chairs with say 80 infusions a day, but there's a total of 9 on our patient panel that actually have white bag requirements.
9 out of, I'm sorry,
Well, so 9 unique patients for that many chairs in our oncology suite would probably see, this is rough estimates, we can come back with patient counts is always a hard thing, but about 5,000 to 6,000 oncology patients, about 9 of them are white bagging. Now that all 5,000 are infusions, it's a little bit of comparison. Very good numbers, but
have you mentioned better adherence with HIV medications? Have you done any internal studies of adherence?
we have, in fact, we've published 3 trials, published these are retrospective analysis of adherence. We actually looked at cure rates because medication possession ratio was interesting. What we were really interested in HIV was what proportion of patients are virally expressed on undetectable viral load. Without specialty pharmacy before that cohort of 800 patients, 55% of them had achieved undetectable viral load. Today, those same 800 patients sit at 85% of the same patients have undetectable viral load of disease rate. In hepatitis C, we showed that using an outside pharmacy and non-specialty, something other than our pharmacy, we were 6 times more likely to failure hepatitis C therapy. We have a better than 90% SPR12 rate, which is the indication of cure from hepatitis C versus in the study it showed about 73% outside. So we absolutely have studied it internally in both QI forums and in research and published those trials. And certainly the hepatitis C is shareable because it's online.
I think if you're able to give anything to us,
I'd be happy to.
quite appreciative of it.
But what we haven't done, as you asked it, is looked at white bagging versus brown bagging. But when we worked with Blue Cross Blue Shield, who, by the way, did work with us when this all happened in 2015, in some cases, because we believed it would be better, we switched from our medical to our pharmacy benefit because we have dedicated people doing that care management, doing the adherence checks, doing the constant care management and check-ins with those patients. We also have software that many of the specialty pharmacies do that EMRs fundamentally lack that tell us when to check in. So if you're on Xylota for gastrointestinal cancer, at day 10 you better check on that patient because they're going to feel really like crap. If at day 60 they start to have skin reactions, they better stop. Well, Epic, Cerner, none of them actually have any capability to tell you that. Our systems do, and as do many specialty pharmacies. So we always call our patients on day 9. We always call them on day 59 so that we can do those types of things.
Just to clarify, you attribute the increase in adherence to the better monitoring systems that you have on the specialty pharmacy side. Is that right? That's not right.
Monitoring systems is actually a great kind of broad way to describe it. That includes people who are dedicated with a panel of patients, software that helps enable their work and to kind of give them tools with which to follow patients on, as well as kind of a number of other things. But both people and software makes up that what you call the monitoring system, which I think is a fair description. Yes.
Thank you. Make sure we get your written testimony.
In fact, I'm just supposed to remind you that Adrian is collecting written testimony.
Yes. Our written testimonies with Adrian already, and we'll follow up with the additional questions.
Okay, thank you. Our next witnesses are Karen Granoff, Dr. Jennifer Lightdale, Neil Gilchrist, and Dr. Sharon Stotsky of the Massachusetts Health and Hospital Association. Welcome.
Good morning, everybody. I'm going to start, and then my colleagues who have far more knowledge than I can speak in more detail about clinical issues. My name is Karen Granoff, and I'm the Senior Director for Managed Care at the Massachusetts Health and Hospital Association, and I'm speaking on behalf of our member were hospitals, health systems, and physician organizations. And of course, we wanted to thank the HPC for the opportunity to provide some comments on this important issue. I'm joined here by Dr. Jennifer Lydell and Neil Gilchrist from UMass Memorial, and by Dr. Sharon Stotsky, and I'll let them introduce themselves in a moment. But before they speak, I just wanted to take a very short period of time to highlight the focus of MHA's concerns, because there's so many different pieces involved in brown bagging and white bagging.
And can I ask you also to, sorry, somebody very close to you. Make it hard to hear for everybody.
So we're really focused on the growing subset of injectable and infusion medications that generally require special handling, storage, temperature control, compounding prior to administration, and may also have significant side effects, and therefore really need to be administered in the presence of a physician. When insurers mandate that these medications must be provided solely by specialty pharmacies, and in some cases administered in the patient's home, the result, as you've heard already, is the creation of significant clinical, operational, patient safety access, and financial challenges to the patient in some cases. In 2016, in response to the growing episodes of insurer mandates on these things, MHA developed principles for specialty pharmacy utilization, which we will share with all of you. These principles, in conjunction with our written comments, clearly outline the dangers of mandating the use of third-party specialty pharmacies and or requiring that certain medications must be administered in the patient's home. Hospital pharmacies bear the responsibility of making sure that any medications administered to patients are obtained from reliable sources, are stored in the appropriate manner, and delivered in timely and unspoiled condition. The integrity of the pharmaceutical supply chain must never be compromised. Coincidentally, there was a report in April released by the National Association of Boards of Pharmacies, which you may have seen, and they stated a shipment of sensitive drugs sitting outside a pharmacy or patient's residence for hours may result in compromised contents and raise concerns about whether the medication was handled appropriately and safely at all times. Some of the additional concerns, which you'll hear more about from my colleagues, focus on those medications with toxic side effects that require extensive clinical monitoring and should be administered only in the presence of a physician. In some situations, changes in the patient's condition may necessitate a change in the dosage or an inability to provide the dosage at all, resulting in either waste or the patient having to come back on another day to receive the medication. These are just a few of the significant issues, and what I'm going to do is turn it over to Neil Gilchrist to talk more.
Thank you. My name is Neil Gilchrist. I'm the manager of pharmacy operations for the inpatient pharmacy at UMass Medical Center at the University campus. Today I'm here to discuss the impact of the growing movement of medications from the medical benefit to the pharmacy benefit being dispensed by specialty pharmacies. Specifically, I would like to cover the medication management process from the time of purchasing to purchasing the hospital and infusion pharmacy practice setting to the time of disposal. At the point of purchasing medications, the FDA enacted the Drug Quality and Security Act in 2013. Title II of this act is the Drug Supply Chain Security Act. The goal of this act was to create traceability within the supply chain to prevent the introduction of counterfeit product and also to ensure the pedigree and quality of medications. The supplier provided medications shipped to a large healthcare system has and continues to introduce risk into the pedigree of very critical and expensive medications. Our organization, and I'm sure others, have had experiences with these medications being shipped to our facility and either left on loading docks or other locations that do not maintain either chain of custody or proper storage conditions. This has resulted in the disposal of medications due to concern of pedigree, created additional costs. In the end of the supply chain for specialty drugs under white bagging, we have no transactional information for these medications, which is required and enforceable by the FDA. Once we have received these dispenses from specialty pharmacies delivered to our pharmacy, there is a challenge with storage. We do not mix a patient-specific Botox or Remicade or other white bag medications with a hospital supplied inventory due to risk of mixing product. Unfortunately, this leads to significant workarounds and cost of both labor and capital. We now manage lists of what we refer to as checked-in white bag medications on an electronic log to track when we receive these medications in the mail by patient name. Due to the increase in volume of white bag medications, we were forced to purchase a separate refrigerator just to store these separate from our hospital inventory of drugs like Remicade. As we store these medications, we then talk about ordering of medications by providers is complicated by this system. As our health record is integrated with our pharmacy inventory system, when a physician in a clinic orders a medication, it automatically queues up for our certified pharmacy technicians to pull and prepare these medications. It is at this point that we need to identify or signal that this patient may or may not have their own supply of medication in our checked-in white bag inventory. This slows efficiency, now having to check the inventory and skips a safety measure of barcode scanned in the medication, introducing unnecessary risk into the dispensing process. Once the white bag medication is pulled from our inventory, the pharmacy team moves the medication into our clean room. We're compounding sterile preparations with medications that we do not have traceability information available, a significant risk introduced into the care of our patients. This is not a risk that the specialty pharmacy or health insurance plan takes, but forced on hospital pharmacies. We are advocating for our patients. There is no need to provide medications that we already stock and treat our patients within the hospital clinic, to then provide a subset of our patients with a white bag inventory. The final points I would like to make are specific examples. A patient is started on Remicade, 10 milligrams per kilo, prescribed at 500 milligrams IVQ every 8 weeks. The medication is filled at specialty pharmacy, delivered to our hospital pharmacy via the mail. The patient on their 6th visit has a significant change in their weight. The dose should be 550 milligrams now, but we've only received 5 vials of 500 milligrams. Do we turn the patient away today because we've checked their weight and asked them to return when the specialty pharmacy sends a new order, a new inventory? Or do we round the dose down to what we have available, providing a suboptimal dose because the patient has taken the day off from work to be there for that treatment? Is this the best for our patients? The second example is in our infusion pharmacy. We have 10 vials of patient-specific white bag Remicade that will never be used. You asked about waste. These are for patients that therapy has been discontinued or modified. The cost of these vials, I would estimate around $5,000. We cannot dispense these to another patient. These are not our medications. These are those patient-specific medications. They belong to that patient. They have expiration dates beyond a year on some of these vials. Do we discard these into the pharmaceutical waste stream, and is this the most cost-effective model as an example of the waste of one medication in one pharmacy? In the 2 examples I provide, these would not be an issue under medical benefit, as we would be able to manage these situations in our supply. I will close with acknowledging that what I have described is considered redispensing, which is not allowed by the Board of Pharmacy regulations. I do not feel comfortable that we are put in this position. However, we must care for our patients and advocate to ensure the regulations support our practice. I urge the Commission to consider that moving medication from medical benefit or this trend to pharmacy benefit with the allowance of white baggage not be in the best interest of patient care.
I ask our other 2 speakers to keep it brief so we can have time for questions.
Okay. So good morning. Thanks very much to the Commission for holding the listening session. My name is Dr. Jennifer Lydell. I am Division Chief of Pediatric Gastroenterology at UMass Memorial Children's Medical Center, and I've been a professor of pediatrics there at UMass Medical School. And I'm definitely excited and appreciate the chance to come here today to provide testimony about my experiences, really what I can talk to as a physician who really has spent her career fully committed to trying to help children with digestive diseases be as happy and healthy as possible. Certainly in terms of children with inflammatory bowel disease, this was and remains a potentially devastating and always lifelong diagnosis that really spares no particular socioeconomic class and involves pain, cramping, and often frequent passage of frankly bloody stools, often throughout the day and night. And certainly as a fellow in late 90s, early 2000, when I was training in GI and spent my first 15 years at Boston Children's, there are routinely 10 to 12 children certainly at that point lying in the hospital often for weeks, miserable, uncomfortable with their parents by their sides, and we just didn't have great options in terms of medications. We were really using prednisone as our mainstay, and despite the fact that it has a lot of side effects, and I'll just go over them quickly for those of you who don't do clinical medicine, but probably recognize somebody on prednisone. There's a lot of facial disfiguring, severe acne, depression in children. We know it can cause growth failure and bone disease. So I actually, I look young, but I absolutely remember life before Remicade and then the life-changing effects it had on kids. So two of my early patients in particular, one is Nick, who I kind of still keep up with. He's now married. But would have been early 2000, he spent 12 weeks of his 5th grade at Boston Children's. And Remicade, when it came out and he went on it, it let him caddy on the golf course, got a job that way, and then ultimately graduated from UMass Dartmouth. And I had another great patient, Rachel, who was 10 years old when I first met her. And I didn't know she was a chatterbox for about 2 years. And then we started her on Remicade, and all of a sudden she was talking a lot. She was in a talented program at Marlborough, and ultimately graduated from the Mass School of Art. I will tell you a couple of years ago, I can't tell you exactly when, you began to experience funny barriers from payers to getting the medication. And in particular, they were insisting on what I now know is called white bagging and sending us the medication, or at least saying that that was how the patient needed to have it. Needless to say, that was very confusing at the provider end, led to countless hours sorting out with our colleagues like Neil on how such a procedure can occur. And definitely led us to understand the incredible processes they go through in the pharmacy, so we don't have to be worried for medication errors. On the clinical sharp end, I can also testify that Remicade is a medication that patients absolutely develop and can have sensitivities to during infusions. Most experience, if they're going to have them, those infusion reactions, not in the first infusion, but later on as they start to develop antibodies to the disease. I will point out that I've had one patient, and I've treated now, hundreds, and probably have been involved in the infusions with thousands. But I have had one who had a reaction with that very first infusion. He's a boy with a lot of allergies, atopy, and asthma. Turned out he had a mouse epithelial antibody, and that led him to have a reaction during the first infusion because Remicade itself has some mouse protein to it. So we just have to be very careful with him, but that medication has made a big difference for him. He was 5 when we first started it, he's now 7. He has a lot of anxiety, not ideal timing, and that his parents were divorcing as we were making the diagnosis. And he's obsessed with the placement of IVs. That's common for me in pediatrics. Kids often hate, anything we have to do to them so much they'd almost rather suffer than get a medication that lets them go to school and have problems. But this is a new thing that we're now dealing with, which is pushing us to the home infusion. So just one quick, just my current absolute experience this month. A colleague in my division has signed his name to an infusion, which a payer is insisting must happen in the home of a 17-year-old we've now been caring for 2 years. This girl, Hannah, presented with terrible disease, intra-abdominal abscess 2 years ago, and a fistulizing process to her perineum, which was very mortifying for her at age 15. Remicade luckily brought the disease under control quickly, and that was good. It was actually quite confusing for us as a team because the family was hard to reach, and it turned out the mother died from breast cancer about 9 months after the diagnosis. So what we are dealing with at the moment is Hannah's between family members, trying to finish high school, go to college, you can only imagine, and we are basically being told that she must have a home infusion. There's been a lengthy attempt over the last 6 weeks on our group to get, we had multiple discussions, written appeals with the payer around this, and basically it has been denied. And so we are now in the process of planning for this first infusion in 2 weeks. And we have to figure out which family member can handle it, because they are trying to care for actually Hannah and her siblings, and most of the family members are at work, so we need a home that there's somebody in the house and their toddlers there. How this is going to play out, we don't know yet, but it is complex. So in the bottom line, I'll end with, as a pediatric gastroenterologist, I know what my patients need. I just want to get it to them as best as I can. And I really appreciate the chance to share the opinion.
Thank you. We're over the 10-minute mark, so very quickly.
Okay, I'm Dr. Sharon Stotsky. I've been practicing in the state since 1984. I'm a board certified internist and rheumatologist. I'm the primary care physician for for many of the rheumatology patients that come to me. I've had an infusion suite since the year 2000. I've done over 20,000 Remicade infusions in my office. And I also practiced rheumatology for 14 years before this drug existed, and I certainly know the impact of moving patients from Social Security disability and living in public housing to keeping their life and keeping their occupation with these drugs. So the patients don't ever want to go back in terms of using these medicines. So I'd just like to comment on, first of all, we did brown bagging versus white bagging. We like just-in-time inventory. We know how many patients we're going to see next week, how many vials we need. That's all we want to have in our refrigerator. We can't keep track of this many patients with this many vials somewhere else. We've had to brown bag visco supplements, which is a chicken cartilage you stick in patients' knees, and there was abandoned medicines. Patients would come for two shots and forget to come back for the third, or they felt okay, so they didn't. Or they would get sick, they'd go to a nursing home, they'd have surgery. So you end up with lots and lots of abandoned medicines. Patients don't tend to have their full, what you plan to give them. There's usually omitted infusions. So I think it's a waste of a lot of medicine if we are not permitted to do just-in-time inventory. We refuse to accept white bagging in the office. We appeal each and every patient so that we're permitted to buy and bill without exception. Because we simply don't have, I think the pharmacists have already explained what the issues are. I agree with them, and I won't go into it. But the insurance plans have been forcing us to try and do this, so we end up appealing them because we can't. We end up with the patient calling the insurance company, the patient's employer calling the insurance company. The patients normally want their medicines, and when they go without their medicines, they're in pain, and then they call everybody. In terms of safety, we've done 20,000 Remicade infusions. We've seen the one in 20,000. Basically, you can have chest pain, high blood pressure, low blood pressure, and you can't breathe. None of that should be happening in the patient's house. It needs to happen with qualified staff. Remicade is supposed to be, it is FDA approved to be given under physician supervision. The American College of Rheumatology also says the same thing, and the American Medical Association CPT code requires it to be given under direct provider supervision. That is not a registered nurse. A provider is not a registered nurse. It can't happen in the home and be compliant with the current set of rules. So Remicade and Rituxan are both written that way. Some other things aren't, but Remicade and Rituxan are not. It's non-compliant with the rules to give them in the home. So that's the safety, and also you just don't want an infusion to happen, infusion reaction to happen. When an infusion reaction does happen, if it's in my office, we can deal with it. It's usually not a showstopper for the patient. The patient can continue to receive the medication. If the infusion reaction happens anywhere else, it usually ends up being a whole to-do with an ambulance, an emergency room, a nurse panicking, and the patient is told you can never get this drug again. In my office, you just get pre-medicated and you get it again.
I want to cut you off, but we're really running out of time.
Okay,
I'm
sorry.
going to get to some questions.
Okay, just on the cost sharing, there's copay assistance. So whether it's a pharmacy benefit or a medical benefit, it doesn't matter if the patient's got a $2,000 deductible. There's a copay assistance, and the patient just has to apply for it. So that's not a showstopper either, other than it's 100%. And that was really all I had to say, other than the fact that the insurance companies have really squashed the markup, and then they do retroactive takebacks. So it's very hard to be able to pay your staff to do this stuff. When they do a retroactive take-back and squash the markup. That's it.
I just want to go back to Neil for a minute. You mentioned that the impact that white bagging has on UMass system. What percent of your patient volume are you seeing that's in the cases that you gave as an example of white bagging?
Sure. I think there's a larger percent in the outpatient infusion area, and I couldn't speak to that percent, but I can follow up with that. On the inpatient side, it's still a small but growing number. And I couldn't give a percent, but I'm going to put somewhere in the 20 to 30 patient realm for a drug like Botox. Nucala is another drug that we're seeing, and then Remicades. Those are the three on the inpatient pharmacy. that stand out to me, but in the outpatient infusion pharmacy, there's a larger volume.
Oh, no, it's right here.
So is there a policy recommendation that therefore you would recommend that the state should be looking at?
Sure, I think there are two things that we need to address. I think the first is traceability. I'll use CVS Caremark is a dispenser. There's no requirement that they need to give us traceability transaction statements. If that continues, we need to have transactional statements for chain of custody of these meds. The second is that, as you're aware, is that this is redispensing, and so this needs to be clarified and updated to reflect. I'm advocating that we do not allow white bagging, but if that continues, that we need to be able to stand behind that if this is considered redispensing and that be updated.
No, well, I think I was confused with the same issue Marty was confused about. So we heard from Blue Cross Blue Shield that any provider can agree to accept the specialty pharmaceutical prices that you buy and bill. And we heard from Dana-Farber that that's what they've chosen to do, that they've chosen to continue buying bill and just accept that price. And then I heard Neil say, and I heard Karen say, that no, there are a lot of providers that have to do white bagging. So, or do, I'm not sure have to, I certainly have to, but, and so I'm confused. Have you chosen to not accept the specialty pharmacy rate from Blue Cross Blue Shield? Or are there other insurers that are requiring the white bagging, even if you say, no, we'd be willing to accept the specialty pharma price?
I would have to follow up about the pricing, and if that has come up. I know that we have tried to appeal to do buy and bill, and that has been denied by some payers. And so that we have policy that doesn't allow it, but unfortunately other organizations also have policy and they enforce it, and then we are a safety net hospital that needs to manage these patients for the region. So, but I can follow up on the pharmaceutical price.
Yeah, I'm very, very confused because what we heard this morning was 85% of patients, 85% of providers stay. Right, so that's what I'm wondering, and then of the remaining 15%, a bunch were used to have specialty pharmacy. So I just don't know what the situation is. Like, are there more insurers that are requiring, that are saying, no, I don't care if you will accept the specialty pharmacy price. We must do this white bagging or brown bagging.
There are insurers that do require it. I don't know. I don't have, in order to get that information, you probably have to ask the insurers directly what their policies are, because there's lots of different insurers, and within each insurance company, there's lots of different products and benefit design. But I think our concern isn't just what's happening now, but as we move into the future, and in other states, they are more aggressive.
So Sharon's, Sylvia's comment was largely about the future. But Sharon, in your practice, are you required to accept white bagging?
No,
So do some, and so some insurers.
You can all of them. I have the list, but I didn't want to name names. My office manager has the list.
The list of, let me just make sure I understand. This is
a list of insurance companies that policy have white bagging, and we don't change and we appeal on every individual patient.
And it's a requirement
It's a
that we white bagging, except if you get a specific exception.
Yes, we do not get paid specialty pharmacy rates, we get paid less than that.
What % of your patient population are those patients?
Just about all of them.
So
Wait, just.
that would mean all insurers are asking you to do white bagging?
Yeah, in general. Linda knows.
Tops out of Pilgrim Valley, Blue Cross, we appeal each and every patient.
Blue Cross said they.
So we got a carve out with Blue Cross because we were, took it to their issue.
But they told us this morning
only
they
the
don't.
rheumatologists that were on the list were on that, so all other rheumatologists cannot buy into this. So they're on the specialty pharmacy list. It's confusing.
We were just told this morning they don't require it for anyone, and now you're saying actually they do require it.
Yes, unless you got into the original carve out 2018. of one of the positions that they allowed.
See the Blue Cross people shaking their heads, no, we're not gonna settle this now. I do think we ought to settle
That's
this,
true.
but even as just this one situation, because we could have a big difference between what the providers here are saying, which is that Plan A requires us to do X, and Plan A saying, no, we do not require X, and so I'm really confused, because it changes the scope of the problem.
But we're in the trenches, we do this every day.
No, I understand, I'm not, so that's why I'm not working.
I would add, as probably most pharmacy departments have added, these pharmacy business offices, we've brought out team members to manage this part of this process. And they are focused on trying to appeal to go under medical benefit, and they've been unsuccessful in situations.
Maybe we've already done this, but have we done a questionnaire to each of the insurance providers on what their practices are? Maybe something we want to.
The issue of medical benefit versus pharmacy benefit, I think, is separate from the issue of internal buy and bill versus white bag. I mean, I understand they can't be the same, but they can also be different. So you could say, yes, you can do it internal buy and bill, but we'll treat it as a pharmacy benefit if it works better for the patient that way. So in my mind, I keep wanting to separate those two, although they clearly go together in the way that it's done now. We also heard that there was, David from BMC said that he thought there were net savings, even though there were some wasted pharmaceuticals, because the prices were low enough, the price savings were low enough to offset the waste. I don't know if that's true or not. You're clearly not on the price side, so that's not the.
I couldn't speak to that, but I know that aside from just the cost of the medication, that we have incurred labor costs of trying to get up workarounds. Essentially, we have folks calling the insurer trying to get it covered under line bill, and so there are definitely other costs that come with this change.
Karen, if you had a way to, we will ask the insurers, as Marty just said, if you had a way to ask your members how many of you are required to do white bagging for even just take Remicade or something, and I'm trying to think of what information would be useful, but we're just hearing very different things, and that makes me uneasy because I don't know what to think.
I'm not sure that we want it. I mean, that's interesting and potentially good information to have, but we know that insurers have these policies, and we know that the industry is moving more and more in that direction, and we know that there's a number of concerns that are raised, patient safety-wise, regulatory, et cetera. So it seems to me that that's really what we want to focus on.
But it matters a lot if it's 5% or 90%, right?
But it still affects practices and patients regardless. And what it is today may be very different than what it is.
So I understand.
And just to be clear, MHA is not, we're not saying that specialty pharmacy should go where, that they should be prohibited or whatever. We're saying that there's a subset of medications that are just not appropriate to be delivered that way, and that they should never be managed.
I think it is so confusing, and on the clinical end, you wind up with people in your office becoming experts. They also learn everything changes usually January 1, so who knows? And then the other thing is, if you keep calling and keep appealing, sometimes you get somebody different and they're interpreting something differently, and all of a sudden it's approved. So there's probably confusion on both sides.
No, this is very helpful. Very confusing.
Thank you all. Please make sure that we get your written testimony, and I appreciate the testimony. We have about less than 5 minutes, but is there anyone else who is seeking to testify who has testified? Hearing none, I will close the listening session. Thank you all for your participation. And again, written testimony is accepted until 5 p.m. on Friday, May 11th.